Good afternoon. My name is Gionna Brown. I'm a third-year Doctor of Pharmacy candidate from Tallahassee, Florida. I'll be doing a journal club article today for Evidence-Based Medicine, Dr. Gervin Robertson's class. The title of my article is Tenofovir Alafenamide versus Tenofovir Disulproxyl Fumarate co-formulated with Entecavir, Covistat, and emtricitabine for initial treatment of HIV-1 infection. 2 randomized double-blind phase 3 non-inferiority trials. Citation and authors are as follows: Paul E. Sachs, David Wool, Michael T. Yin, Frank Post, Edwin De Jesus, Michael Sag, Anton Ponziak, and Melanie Thompson, just to name a few. The funding was planned and conducted by Gilead Sciences. For the background, tenofovir disulproxyl fumarate is an essential part of one of the most used NRTI backbones of the HIV therapies. Tenofovir can cause renal and bone toxicity when in high plasma concentrations. Tenofovir alafenamide is a unique tenofovir prodrug with a 90% reduction in plasma tenofovir concentrations. A 2.5-year phase 3 clinical study shows that tenofovir alafenamide containing regimens have been improved renal and bone safety compared to the tenofovir disulproxyl fumarate containing regimens. The methods. Objective. The objective of this study is on the novel drug of tenofovir alafenamide showing similar antiretroviral activity with significant reduced effects on estimated glomerular filtration rate, tubular proteinuria, and bone mineral density in comparison to the tenofovir disulproxyl fumarate. Tenofovir alafenamide, which I'm going to abbreviate TAF, results in roughly 4 times higher intracellular concentrations of tenofovir diphosphate fumarate, which allows for a reduced dose and improved stability, and plasma exposure of tenofovir is 90% lower, which reduces the risk of renal and bone toxicity. Therefore, it's basically saying that the tenofovir alafenamide at a lower dose contains a higher concentration than tenofovir disulproxyl at a high concentration. So you're going to be basically using less of the tenofovir alafenamide to get the same effects as the tenofovir disulproxyl at a high concentration. Therefore, they're going to see just about if we use the tenofovir alafenamide, would that give us a better side effect profile than using the regular TDF, which is tenofovir disulproxyl fumarate. The trial design was randomized, double-blind, multi-center, active control phase 3 trials. The location was done at 134 sites in North America, Europe, Australia, Japan, and Thailand, and 128 sites in Europe and Latin America. The IRB approval undertaken is in accordance with the Declaration of Helsinki and was approved by central or site-specific review boards and ethic committees. All patients were given a written informed consent. Inclusion. Patients with HIV-1 and no previous antiretroviral therapy had HIV-1 concentration of at least 1,000 copies per milliliter, an estimated glomerular filtration rate of at least 50 milliliters per minute. Eligible patients had screening HIV-1 genotype showing sensitivity to Entecavir. Patients with the exclusion. Patients with positive hepatitis B surface antigen, patients with hepatitis C antibody, new AIDS-defining illness within 30 days of screening, patients under 18 and without HIV-1 infection. So those were the patients who weren't able to be a part of the study. Subjects. There were 2,175 patients screened for both studies, of which 17,444 were randomly assigned to receive treatment. 866 patients received Striblid, which is a combination HIV therapy with tenofovir alafenamide instead of tenofovir disulproxyl fumarate. 867 patients received Striblid with the combination of the TDF, which is tenofovir disoproxyl fumarate, which is the normal, or the most common combination within Striblet. Patients stratified by HIV-1 CD4 count and region at screening. Primary endpoint. It was 48 weeks total. Post-baseline study visits occurred at weeks 2, 4, 8, 12, 16, 24, 36, and 48. Laboratory tests included hematological analysis, serum chemistry tests, fasting lipid parameters, and CD4 counts. Measures of renal function, estimated glomerular filtration rate, urine protein to creatinine ratio, urine albumin to creatinine ratio, retinol binding protein to creatinine ratio, the B2 microglobulin to creatinine ratio, fractional excretion of uric acid and fractional excretion of phosphate, and measurement of HIV RNA concentration. The secondary endpoint, 144 weeks total. Additional testing by treatment responses by subgroups, proportion of patients with plasma HIV-1 RNA less than 50 copies per milliliter when classifying missing as failure and missing as excluded. Patients with HIV-1 RNA less than 20 copies per milliliter by snapshot, change in CD4 count from baseline. The follow-up, 24 weeks total, dual energy X-ray scans of lumbar, spine, and hip at week 48, 24 weeks after endpoints to measure percent changes in bone mineral density. The duration was 2.5 years for clinical study, but 28 weeks to primary endpoint. The population was 2,175, and then there was the 17,000 that were used. The arms. The tenofovir allofuramide plus attegravir, emtricitabine, comistat was, and then you also had the placebo of that. Then you add the tenofovir diproxyl fumarate, altegravir, emtricitabine, comistat. These combos are also called Striblet for short. That's the brand name. And then there was a placebo for that. The statistical analysis. For the statistical analysis, we had the 2 phase 3 studies combined for pre-specific pooled efficacy and safety analysis on a percent of 0.001 was spent. Significance level was for the one-sided non-inferiority test and primary analysis at week 48 was 0.02499, equivalent to a two-sided 95% confidence interval. Percentage difference in associated confidence interval were computed with a baseline HIV-1 RNA concentration and region stratum, adjusted Mantel-Hansel proportion. They used a Fisher exact test to compare treatment differences for adverse events and a Wilcoxon-Rank-Sum test to compare treatment differences of continuous laboratory test results. The Fisher exact test is a statistical significance test, and it is used in the analysis of contingency tables. Exact tests that shows significance of the deviation of the null hypothesis, which is the p-value. The Wilcoxon-Rank non-parametric test of the null hypothesis that tests 2 samples come from the same population against the alternative hypothesis, especially that a particular population tends to have larger values than the other. It has the greater efficiency than the t-test on a normal distribution. Such a mix of normal distributions, and it is clearly as efficient as a t-test on a normal distribution. Now we will move on to the baseline characteristics. Our baseline characteristics are as follows. It's more on the table, but the age was roughly around 26 to 42, which had a mean of 33. There were the women that received the Striblet with the tenofovir alafenamide roughly had about 133 women, and those who received the Striblet with the regular tenofovir diproxyl fumarate were 127. And then the table also has more. All right, our baseline. Now we're going to our primary endpoints. Proportions of the patients with plasma HIV-1 RNA less than 50 copies per milliliter and pre-specified renal and bone endpoints at 48 weeks, centrally assessed. Efficacy in the baseline HIV, RNA, and CD4 subgroups. Efficacy in selected subgroups. Tenofovir alafenamide was non-inferior to tenofovir diproxyl fumarate for combined primary outcome. With a cutoff of fewer than 20 copies per milliliter, virological outcome at week 48 had difference of 0.4%. Viral suppression was high of both treatment groups for per protocol analysis with a difference of 1%. Secondary endpoints. I also have figures and tables to go along with this. I understand that you're not going to be able to see, but within my presentation, before each figure, I have where it's going to be should be placed within my journal, and at the end there's going to be the figures and tables. Again, I do apologize. For the secondary endpoint, I do have a figure. It will show you basically the significant differences in efficacy for those with fewer than 100,000 copies per milliliter baseline HIV-1 RNA. 94% for the striblet with the tenofovir alafenamide versus 91% for the tenofovir disoproxyl fumarate that was in both the striblets. The mean increases from the baseline in the CD4 counts were, the mean increases from the baseline in the CD4 counts were higher in the striblet with the TAF group through week 48, other than the striblet with the TDF, which is the tenofovir disoproxyl fumarate. The adverse events. One table shows that diarrhea was most common side effect with 17% in the striblet with the TAF group compared to the 19% in the striblet TDF group. The next most common adverse event was nausea, headache, and upper respiratory tract infections, with each incident being higher in the TDF group except for headaches. Headaches, they were roughly about the same. Adverse events leading to study drug discontinuation were uncommon. Five patients did die using the striblet TAF, and some were due to poisoning as well. 3 patients had decreased glomerular filtration rate, and another patient had developed neuropathy, all believed to be drug-related. Patients using the striblet TAF group had significantly less reduction in bone mineral density than those using the striblet TDF group through the 48 weeks. Greater increases in the fasting lipid parameters, total cholesterol, direct lower density lipoprotein, high density lipoprotein, and triglycerides, but they had identical changes in the total cholesterol to the HDL ratio in patients given the striblet TAF compared to those given the striblet TDF at week 48. Within the author's conclusion, the striblet TAF provided non-inferior virologic suppression, as well as showed significantly more favorable effects on renal and bone parameters. They also had favorable to mild to moderate adverse effects, and they were shown to improve the safety with higher efficacy rate. And so that is basically saying that now that they see that there's possibility that the tenofovir alafenamide may become the more drug of choice when compared to using the tenofovir disoproxyl fumarate, when it comes to patient safety as well as drug efficacy. The strengths: it was double-blinded, multi-center, randomized trial. 1,744 patients were used. Comparison to the new drug, they were able to compare a new drug versus the standard drug. And so the standard would be the TDF, and the new drug would be the TAF. It was ethically diverse, and it had a 95% confidence interval and a broad age range. Weaknesses: women were involved in the study. The study only reviewed patients after 48 weeks. It was some patients had HIV type 2, advanced HIV stage, no CD4 baseline. It didn't really have that many patients. Well, it had a lot, but it didn't have as a broad amount that they wanted. The study was not conducted in Africa. And I believe the reason why they feel that that may be a weakness was because everyone has this theory that HIV originated from Africa. So they would believe that a majority of the people within Africa either had HIV, or also because of the population. They do have a greater population than the majority of the countries around the world. According to the author, although the long-term clinical significance of these findings is unknown, it is reasonable to expect that these results will translate into improved safety for the TAF-based antiretroviral therapy over years of treatment while maintaining a similar high efficacy rate. Resistance mutation developed was similar between both treatment groups. All patients with emergent resistance developed the reverse transcriptase mutation. All of these effects were probably related to the markedly lower plasma concentrations of the tenofovir reported with tenofovir TAF than compared to TDF. Conclusion: TDF causes renal, bone, toxic effects related to high plasma tenofovir concentrations. TAF-containing regimens have shown to have improved renal and bone safety compared to TDF-containing regimens. Even with a 90% decreased concentrations of tenofovir, the efficacy of TAF was non-inferior, with lower adverse effects on kidney and bone toxicities. Osteopenia and osteoporosis in patients with HIV infection still has high prevalence, especially in patients with TDF in combination with protease inhibitor-based regimens. The issue is that the mechanism of TDF-related reductions in bone mineral density is poorly understood. Still, questions concerning the long-term effects of lipid profiles show after the 48 weeks that this study was conducted for. Alright, and again, I just have the tables uploaded. Also, I would like to add on to the weaknesses. They also said that because of the low power to assess real clinical safety events such as renal adverse events and fractures to the patients with limited baseline risk factors and kidney bone densities. So, in conclusion to this, it's basically safe to say that they're not completely sure when it comes to which studies show that the TAF had better side effect profile than compared to the TDF, but because of the population size, they aren't completely sure that that can be a safe bet to go off of on if we should change our drug of choice when compounding Striblet to change it to TAF instead of TDF. I do thank you again for listening to me. Hope you all have a great day.